Welcome to the JPIAMR series of interviews, and this time we're focusing on the members of the Strategic Advisory Board, the SAB, and we're fortunate today to have the newly elected chair of the SAB. It's Professor Till Bachmann. Welcome, Till.
Thank you very much, Anders, and yeah, I'm glad to be here.
And we are happy to have you with us. And first, let me just note a few things about your background. You are a professor at the University of Edinburgh, that we can tell from the nice picture behind you. But you're also the deputy head of infection medicine at the Deanery of Biomedical Sciences at Edinburgh Medical School. You're AMR strategy lead for Edinburgh infectious diseases. You're also coordinator of the UK-India project DOSA, and we're happy to have you as coordinator of the JPIAMR-VRI network, AMR DX Global. So that's part of your background. I know that there's much more to fill in, but we're happy to have you in the role as the new chair of the SAB.
Thank you. And I'm excited to start with that role. Obviously, it's a huge opportunity, and yeah, glad to be part of this tremendous network.
And I think you have been involved in so many JPIAMR related things. You also in Stockholm in 2019 when we had the Hacking AMR hackathon. And you've been moderator at several events and workshops that we've had. And I actually visited you in Scotland a few years ago. So I've seen the works of Diagnostics, that is your field for real. So this is, it's such a pleasure to have you with us still.
Yes, indeed. And I must say, as you say, I have been involved with JPIAMR for a while. I saw it growing and I saw it delivering, and the various different types of activities JPIAMR is offering and is initiating. And yeah, I'm really glad to be part of this initiative now in a different role. But it's really, JPIAMR has developed in a key player. It has always been or has quickly been a key player in the AMR world, but it's even more so developed in something influential and driving our activities together in tackling AMR with research.
And SAB, the Strategic Advisory Board, you're going to be very instrumental when it comes to updating the SRIA, the Strategic Research and Innovation Agenda that is going to be underway this spring, and much awaited for, you can expect as well from the scientific community, guiding the path forward when it comes to AMR research.
That's correct, yes. So the SRIA update will be our next in spring. It's actually I would say the next months, next year almost, where we'll be dealing with that, and clearly there will be a lot of activities, consultations, and yeah, contributions through the SAB and beyond going into this. And I think from a perspective of the SAB, what we should mention is that we have the term in the Scientific Advisory Board of Membership. You have 2 terms if you want, 2 years. So we have just an influx of new members into the SAB, which is really good. And there we specifically also looked into complementing, of course, the expertises in the SAB. And I think we are really well set to address the SRA update now.
And the consultations will be opportunities for researchers to participate in this work as well.
Indeed, yes, yes. You mean external researchers, which are beyond the SAB? Yeah.
Yes, exactly. The whole the research community when it comes to AMR is going to be invited in several ways, I believe.
Absolutely. This is through the very focused groups, but also in terms of public consultations, and events where, yeah, as you say, the scientific community is contributing that to the SRA. Again, that's a feature of JPIAMR to be a very open initiative and for members and participants to contribute.
But tell me a little bit about your focus going forward, Till. You're the new chair of the JPIAMR Scientific Advisory Board. What are you going to focus on in your role?
Well, first of all, I think it's important to say that in my role as the chair, the chair is a moderator which helps with the communication with the other bodies of JPIAMR in the governance, and so I'm not steering the SAB, or I'm not I may be the chair of meetings, but clearly what I have in mind is that we need to is the SRA update, and that's the key objective. And there, my objective will be to ensure that we have this broad coverage of disciplines, that we ensure that the input in the different research domains which are contributing to AMR, or which we need to consider for tackling AMR, are equally considered. So obviously my background is in diagnostics, but I'm not there to drive diagnostics in the SAB, well beyond that.
But you are an expert on diagnostics. It's one of the priority topics of the JPIAMR SRIA. If you, a little bit out of the box, what are the key developments right now for diagnostics from your view?
Well, the key development for diagnostics, the key events for diagnostics are, unfortunately, outside AMR, are in COVID. With COVID, all of us have experienced diagnostics in our daily lives. They have become almost a commonplace. Everybody now, even in the news, you hear people correctly pronouncing PCR and antigen tests and everything. So that's really a commonplace, and that's good for diagnostics, absolutely good. So that's the implementation, the acceptance of diagnostic as something which contributes to tackle a healthcare issue, a public healthcare issue, and a very personal impact for people as well. So from an AMR diagnostic perspective, that's very positive. And then, of course, what was interesting with COVID as well was that the technologies which have been actually used at the end were not new technologies. In fact, very old technologies, especially around lateral flow. That tells us something. That tells us that it needs a proven technology to succeed in a very wide-scale application. I wouldn't say that we always need old technologies. Of course, there is innovation in the lateral flow assays as well. Of course, there is, and there's really great innovation there. But it's not that we always need, or we only need new technologies. On the technology front in AMR, there are a number of good developments. It's really, we have a sea of technologies. We have a sea of new tests coming up. From my perspective, because I'm doing research on technologies and on diagnostics, we are very interested in rapid pathogen identification. We're very interested, we as a community, interested in biomarker identification, in rapid antibiotic susceptibility testing, as well as AMR testing, so rapid AMR testing. Now, surveillance is always very close to diagnostics, and from that perspective, of course, technologies like next generation sequencing feed into this. Again, we learn from COVID here, or we see on the COVID examples, how surveillance can benefit from that. But there, as I said, there are, for different, depending on the requirements, you have different technology solutions, which are one part of the solution which needs to be implemented.
Is there any experiences from diagnostics in a COVID context that can be drawn when it comes to AMR and the need for diagnostics in that context?
Yeah, so it's an interesting question. Any experiences? I would say it's from initially when we started looking at COVID, the biggest challenge we thought was the detection of very low amounts of viruses and very low amounts of RNA. In fact, I would say that what was very quickly resolved. Low detection limits is something that you can achieve. What turned out to be really challenging, and we all have experienced that when we try to take a swab from our throat or from our nose, that getting the sample is actually is decisive and for the result of the test, but also, of course, for the implementation. And that's a learning which we knew already that this is challenging in AMR as well. So getting the right sample. Let's say if you take a bloodstream, to detect bloodstream infections, when you take your sample, you need to make sure that you don't contaminate with skin flora. Same with urinary tract infection. You need to make sure that you don't contaminate your sample with bacteria. So there, it sounds trivial, but it isn't, and it's quite a challenging hurdle to overcome. That's a lesson learned, or a supportive lesson or example which we get from the COVID experience.
Interesting. It's a topic that we can speak all day long about, but switching focus a little bit, another topic that many are talking about and have been talking about is the Lancet report that came out a few weeks ago, the global burden of bacterial antimicrobial resistance in 2019, a systematic analysis that said that in 2019, 1.27 million people in the world died of AMR or of resistant bacteria. What is your take on that? What are your thoughts about that report and the implications it brought?
Yeah, I mean, it's an amazing piece of work, first of all, so congratulations to, the huge author list, as you all know. So really, really amazing work. I think comes at a crucial time, the work, the publication, for many reasons. One is certainly that we have all the feeling that we come out of COVID just now, and focus seems to refocus from the pressing COVID need to other healthcare needs, and AMR is one of them. So AMR was always there during COVID, of course, because of the associated antibiotic consumption with COVID infections, of course. But now we have an evidence, a paper which shows about the burden of AMR globally. Now, there are, I think, two figures. You mentioned the 1.27 million deaths attributable to bacterial AMR, and then you have an even bigger number, 4.95 million, to deaths associated with bacterial AMR. So that's related to the way the authors did the modeling, and how they, which pathogens they and infections they included, and syndromes. So these are huge numbers, and if you look at the scenario, is that the last time we had these postulations or these modeling of numbers were with the review on antimicrobial resistance. 700 deaths, 700,000 deaths in 2014 was published by the O'Neill Commission, and then we had the projection of 10 million deaths by 2050 if we don't do anything. Now, really important is that these numbers which we are now seeing in these publications are not way off from what we have seen before. So they confirm what has been modeled before in essence. If you look at the details in the publications, they come very, very close to what has been said in the O'Neill report and elsewhere. And so that's a confirmation. It's a confirmation of the grave importance of AMR and the grave impact AMR has on our healthcare system. So I think that's a key thing. So it's a reiteration of the problem. So it's really important that we deal with that. The granularity of the report is, for example, they looked at pathogen drug combinations, so very more specific look at impact of those. It looked very specifically at geographic situations. So how does geographies play into there? So as a tool for policymakers, for researchers, where to put the emphasis on, this report is really important.
Will it affect the work you're going to do in the strategic advisory board, do you think?
We will for sure consider this.
Mm.
I mean, it has been in the discussion across many different settings. I've been in the discussion recently since it was published, for sure. And again, it's important to flag the issue to the general public, and that report, as did before the review on AMR, very excellently did to raise the profile of AMR. This report certainly helps with that as well.
There's I've heard Dame Sally Davis saying that the silent pandemic is silent no more, since this report came out. Kind of frames the importance of this information and the impact of the report.
Very well said. Yes, yes, indeed.
So that brings us to the next topic, that when we're thinking about the One Health approach that is central to JPIAMR's work and to coordinate research funding and research. To date, JPIAMR, we have coordinated funding of some 125 million euros in total, and diagnostics is one of those priority areas. How does these calls make a difference for diagnostics and AMR? What do you see there?
I mean, first of all, money is always important for any researcher. So very selfishly, I would say this makes a huge difference for researchers. If you don't receive funding, you can't do research. But JPIAMR funding, any funding which I can see from JPIAMR, which I received myself or others, is so much more than the funding itself. It's the network you are provided, and there specifically JPIAMR is providing huge input. So you receive funding, but you receive this opportunity to connect with other researchers. From that perspective, for diagnostics, but for any other domain, it's of crucial importance. There is an upcoming network call for diagnostics in JPIAMR, so clearly that will be of high impact, I would say. I've been coordinating networks before. We had a lot of very positive outcomes from that. So for the diagnostics domain, that's it's very crucial that this funding is coming. I think it's also important that we keep diagnostics, or maybe the diagnostics community gets more aware of the One Health agenda and the One Health context, because it's very easy to just focus on the human setting or on your animal setting. So, but to look where interaction points are, where it can be cross-fertilization, of course, transmission, all these aspects of One Health. Let's say transmission is the classic, but aspects of One Health go way beyond the transmission. So I think for the diagnostics community, that's of huge importance.
We could have a live stream 24/7, I think, about diagnostics and AMR, can't we?
As well.
Yes. But we need to round off this nice interview, Till. And here's the one last big question for you. If you could wish for one big thing to happen in the field of diagnostics, and of course linked to the challenge of AMR, what would you wish for? Anything is possible.
You mean from JPIAMR perspective, or
I'm thinking about from your perspective, and also being part of JPIAMR, but also in a broad sense, that what would be a kind of a game changer when it comes to diagnostics and AMR?
I can tell you why I joined this whole AMR activity. Was when I first learned how antibiotics are prescribed in the hospital. I was really surprised and shocked. So, I mean, of course, at that time I didn't understand. This was earlier in the career. I didn't understand the implications, why things were run. But empirical prescription or empirical use of antibiotics seemed really strange, because I would have thought, yeah, well, there is diagnostics, but there wasn't. So if you and still many years later, it's still the same, more or less. So if you would ask me what is the one big thing is that we need to make sure, we need to ensure that diagnostics are somewhere used. If you look at the Lancet Commission on Diagnostics, they had a very nice publication about access to diagnostics. So almost half of the population of the world has little to no access to diagnostics. That's shocking. So that's the one big thing is, if I could have a wish, make diagnostics accessible. They need to be accessible to make a change to AMR, to many infectious diseases as a whole, and other diseases. So diagnostics is, I think, completely undervalued in terms of its impact to healthcare and to the living public health of people. So obviously JPIAMR can't achieve that by themselves, but they can contribute to that. And I think from a funder perspective or from an intervention perspective, we do far too less studies where we look into what diagnostics could actually do. We need evidence for positive impact of diagnostics on the AMR situation. So studies which generate that impact will help the field altogether. So that's the one big thing I can ask for.
That was exactly what I was thinking of, that I hoped you would answer. A new big challenge and goal for diagnostics, and how to meet AMR as a challenge for humankind.
Yes, be a bit bold and come up with, let's say, pull incentive for diagnostics. This has been talked about, not implemented. That would be nice. Be bold, be ambitious, get diagnostics out there, facilitate it for developments to be demonstrated, hotbeds of diagnostics which show they have a positive impact. And again, coming back to COVID, nobody would dispute the positive impact diagnostics had there.
And we can hope for AMR that we will have that same impact. Perfect ending, Till. Thank you so much for taking time all the way from the University of Edinburgh to the studio in Stockholm. And we wish you a big good luck with the work that you're doing in the SAB, and now in your role as the new chair. What can be better?
Thank you so much, Anders, and I hope next time we can actually meet in Stockholm.
Exactly.
Although you're always welcome in Edinburgh.
I hope to return there and hope to see you in Stockholm soon, or anywhere else in the world.
Fantastic. Thank you very much.
Thank you. Take care.